Ladies and gentlemen, esteemed colleagues, first and foremost, while I wish I could be with you in person today, I extend my heartfelt gratitude for the privilege of being invited to address this esteemed gathering at the DADA2 conference. Now I would like us to delve into the intricate world of neurological manifestations in DADA2. Neurological complications, including strokes with various neurological symptoms, pose a significant risk to patients. They are just one facet of the complex neurological landscape in DADA2, which also encompasses conditions like transient ischemic attacks, encephalopathies, sensory neural hearing loss, ophthalmological abnormalities, and neuropathies. These symptoms can precede other manifestations or manifest independently. In light of these challenges and the need for increased clinical awareness, our recent paper provides a comprehensive review of DADA2-related neurological complications, bridging the gap between clinical reality and our understanding, with the aim of facilitating early recognition and management. So we reviewed the available data on patients diagnosed with DADA2 published between 2014 and 2022. The research was conducted manually via PubMed using the following keywords: ADA2 deficiency or adenosine deaminase 2 deficiency or DADA2. After all articles describing the clinical features of DADA2 were included in the analysis. Articles that were not in English were not included in the study. Papers containing insufficient clinical descriptions of patients were excluded. This was evaluated by full text screening. And in case of duplications of cases, only the most recent report or the report with a more complete clinical description was included. So we delved into the data, uncovering a total of 628 patients diagnosed with DADA2 from a final number of 129 papers. Our aim was to analyze their demographics, genotypes, and clinical characteristics. So to start with, as you can see on the slide, among the total of 628 reported patients, the male population was slightly prevailing. 46% were female and 54% were male. The mean age of the disease onset was estimated as 7 years old, ranging from the birth to 59 years. Of the patients with reported ethnicity, 50% were European, 16% hailed from the Middle East, another 16% from South Asia, 10% from East Asia, and the rest sprinkled across North Africa, Latin America, and beyond. The pathogenic variants were reported for 495 patients, which makes it 80% of the reviewed patients. 277 patients had a homozygous variant, 205 compound heterozygous. 12 patients had one heterozygous variant with an unknown second mutation, and one had both homozygous and heterozygous deletions. There were different types of mutation identified, and they occurred all over the gene. Now I'd like us to move on to the clinical characteristics. Out of the patients we looked at, a considerable 50.3% experienced some kind of neurological event. The average age for these events was 7.2 years, ranging from birth to 36 years. A total of 245 patients, making it almost 80% of all neurological manifestations had at least one cerebrovascular accident. Not unexpectedly, this pattern held true even for the pioneering DADA2 patients initially described by the NIH and the research team in Israel, who also manifested with stroke. The cerebrovascular accidents included 115 ischemic, 61 hemorrhagic strokes, and 5 transient ischemic attacks. A striking number of 88 patients had multiple stroke episodes, and 34 patients presented with neuropathy, and other neurological involvement included focal neurological deficits, ophthalmological findings, convulsions, headache, and specific findings like dizziness and amnesia. In addition, cerebral atrophy, white matter changes, radiographic findings of brain anomaly, and 5 patients with unspecified neurological findings were reported. I would like to note that some neurological signs of CNS involvement can be underestimated due to their mild or transient character, like TIA or silent infarcts, or due to the possibility of MRI negative findings. MRI negative findings while infarcts, particularly in the brainstem, which may be missed without the use of thin cuts or higher magnetic field strength. Thus, it is crucial to exclude DADA2 whenever a patient presents with an acute stroke at any age, especially in childhood. Besides other non-atherosclerotic arteriopathies, such as arterial dissection, focal cerebral arteriopathy, and moya-moya vasculopathy, DADA2 should be in the differential diagnosis of arterial ischemic stroke in childhood. Interestingly, 18 patients, for 18 patients, a neurological event represented the initial presentation of DADA2. Moreover, for 2 of them, it was the sole manifestation of the disease. This finding resonates with the recent study by Vershoff et al. Titled Neurological Phenotype of Adenosine Deaminase 2 Deficient Patients, a cohort study, which reported an even higher incidence of 28% of patients in their Netherlands cohort presenting with TIA or ischemic stroke as the initial symptom. It is worth noting that the existing literature and awareness of DADA2 largely stem from rheumatology or immunology studies, potentially resulting in a skewed representation of neurological manifestations. Moving on to the next slide, 22 patients had neurocognitive disorders. This included isolated cognitive impairment, isolated memory disturbance, autism spectrum disorder, attention deficit hyperactivity disorder, isolated persistent irritability, and isolated difficulties in concentration. We hypothesized that the actual number of patients with neurocognitive disorders may be even higher than reported due to the underdiagnosis. Also, whether this is only a coincidence or the discrepancy is due to a direct effect of DADA2 or an indirect impact of the context of severe disease is unclear at this stage. This fact should be anyway be taken into consideration in patients with DADA2, and the evaluation of these conditions should be part of routine management of DADA2. According to the review of neuroimaging results, the most common CNS lesion during DADA2 is ischemic stroke, with most common localizations in the brainstem, thalamus, basal ganglia, internal capsule, and other deep cerebral structures, representing the pathological involvement of deep perforating arteries. Could I just draw your attention to this table of MRI lesion distribution? As you can see here, lacunar stroke cases comprise 63% of the available MRI findings, of which 90% were located in the deep gray matter or brainstem. Interestingly, this preference on MRI is similar to the preferred locations in Behçet's disease, another immune-mediated vasculitis, albeit that lesions in Behçet's disease are often not infarcts. This parallel between the imaging pattern of ADA2 deficiency and Behçet's disease has not been reported onto our knowledge, yet an overlap from a clinical perspective and genetic perspective has been described before. Vascular wall enhancement of small perforating arteries has also been reported, but may be underrepresented because of the absence of vessel wall imaging sequence in studies. Interestingly, intracranial calcification, the hallmark of Aycadry-Gutierrez syndrome, the archetypical interferonopathy, are typically absent in DADA2 patients. This is noteworthy considering the involvement of enhanced type 1 interferon signaling in DADA2 patients and the consideration of AGS in the differential diagnosis. Well, then to conclude, let me go over the most important points here again. So neurological manifestations are prevalent in DADA2, affecting over 50% of patients, and the spectrum is diverse. Onset of neurological symptoms typically aligns with the general onset of DADA2 around 7 years of age, although adult onset cases occur. Strokes are the most common neurological event, sometimes presenting as the initial or sole manifestation of DADA2. And neurological signs can be subtle, emphasizing the need for clinical suspicion and evaluation, especially in patients with unexplained neurological symptoms. DADA2 patients may display a characteristic neuroimaging pattern with lacunar and infarcts in the brainstem and deep gray matter structure. Recognizing neurological symptoms as potential indicators of DADA2 is crucial for timely diagnosis and better outcomes for the patient. Thank you for your attention.
Well, fantastic, Maria. That was really great, and it's wonderful to have you present your recorded talk, and now to have you in person. Well, kind of in person, anyway. And we already have a question for you from Julie Williams.
Hi, Dr. Zeus. Thank you so much for the presentation. I appreciate your review. I'm the genetic counselor at the Foundation working on the patient registry. And as I've formulated our systematic body survey to ascertain those early and emerging symptoms for patients, obviously neurological affecting half, as you report through your review of DADA2 patients, makes it paramount. And if you are thinking that, I think it read on your side about 5.7% in your review were the initial presentation as neurological. So that tells me that we need to capture more neurological findings as we start to fill in our registry. I just kind of wanted your comment on this. We've been working on the body system survey for the patients to report of the 134 diagnostic symptoms that are known, kind of head to toe through the diagram of the body. But we have another portion that we developed that's more visceral. So it's taking 10 to 12 symptoms that a patient may experience, like tingling or numbness, difficulty moving, things that a parent of a patient at 7 or 8 being diagnosed, may be able to report, oh, yes, my child has difficulty using their left hand. Would you be able to comment on how important that sort of assessment would be, in your opinion, now that you've done such a methodical review? How can we capture these neurological symptoms as they emerge in our patient population? And I'm happy to clarify.
Yeah, thank you. Thank you for your question. As you saw from my presentation, the spectrum could be really very wide, and yeah, we kind of know what to do with the strokes and how to identify them. And we know that there is for the stroke specifically, the TNF alpha treatment helps, but not for the all the other spectrum of neurological manifestations. It's not clear that these can be solved. And indeed, well, I'm not sure if I can answer like how exactly how to screen them. Well, neurologist consultation and just keeping track of new symptoms that occur in patients. I don't think I have some special.
I guess my question, more pointed question would be, is there kind of a concurrence between neuropathy symptoms or other things that you saw in the review that are concurrent with stroke or before the stroke, preceding stroke, that we could be mindful of in our population?
Okay. Yeah, I'm afraid not.
Okay.
But, it certainly, just to butt in here for a moment, it could certainly be that if a patient is complaining of numbness in a certain part of their body, that could be because of a mononeuritis multiplex, from a vasculitis kind of picture, rather than that it would be a central lesion. Yeah. So that might be another reason for interrogating about that. So you raised the question of the similarity, or not the question of, but you pointed out the similarity between the distribution of stroke in DADA2 and the distribution of stroke in Behçet's disease, which I think is an interesting observation. And maybe this is a little bit off that topic, but at least this popped into my head when you said that anyway, and that is, are there common variants of the ADA2 gene that come up in GWASs having to do with stroke, in the general population? Do you have any information on that?
Sorry, can I ask you to repeat the last part?
Yeah, okay.
I'm sorry.
So I'm talking about, the fact, so we're dealing in DADA2 with rare variants, that rare high penetrance variants that are associated with deficiency of ADA2, that clinical disease. What I'm asking is, what about lower penetrance common variants in the ADA2 gene? Are they associated with stroke in the general population? See what I'm saying?
Yeah, I think there is no yet identified link between the variants and the stroke, occurrence of stroke.
Okay, in the general population.
Yeah.
And should we advise our patients with DADA2 to eat a healthy diet, low in cholesterol and saturated fats? Because that might be another risk for stroke.
Definitely, yes. Yes.
You agree with that? Okay. All right, thank you.
do.
All right, other comments or questions?
Oh, thanks for this wonderful work. I just had a little comment. I think the hemorrhagic stroke was a bit more represented in your review than we would expect. So just a caveat that maybe some of those were secondary to some treatments they had received versus like a primary. Of course, it can occur just from ADA2, but is much less common than the ischemic stroke.
That's true. That's why we do have to keep in mind the treatment of stroke in the DADA2 population is different than in patients without DADA2. So yeah, we do have to be aware of secondary hemorrhagic stroke possibility, and yeah, it might be secondary in the review, but that was reported in the other 2 patients with no identification that it was secondary.
All right, any other comments or questions? Okay, if not, Maria, thank you very, very much.